So I'll take us home. My focus today is to give you kind of a snapshot of what the evidence is telling us about orthotic management. When I started to put this together, this is certainly not a systematic review, but I guess probably the best way to describe this is a 30-year or almost 30-year reflection on the times that I've gone to the literature and what the literature has told me. And so I've gone to the literature for various reasons. Certainly the most obvious would be clinical application. I've gone to the literature, obviously, when I've done research. The same with teaching. We're teaching, we want to make sure that we're providing the best evidence for our students. And then finally, this publication that we recently did. What I see to be a consistent pattern, and there are two things really to kind of come out of this talk, is I think there's an opportunity for better training of our students, and I'll give you an example of that. But I think our biggest flaw when I look at the research is that the methodology is frequently flawed. And there's a number of factors that are just not controlled for when you really do a deeper dive and look at a number of these papers. So if we take these, I broke these down into diagnosis, methodology, and the outcomes. I think if you take adolescent idiopathic scoliosis, that probably right now, if you look at the entire genre of spinal orthotic management, has the best track record when it comes to research. And I think increasingly, if you look at the methodology is certainly more sound than when you compare it to some of the other pathologies that we look at. In terms of our outcomes, and John mentioned those, when we look at adolescent idiopathic scoliosis, we're certainly looking at trying to prevent curve progression, the prevention of surgery, those type of outcomes. When we start to look at things like low back pain, we look to the outcomes being things related to, is a person able to go back to work? What is their activity level? Certainly looking at pain scale. But when you regress back to the methodology, the problem is, and I wrote this down because John made the comment, what is your orthosis doing? I think that's where we're falling short. And I'm seeing some nice presentations that are going to be taking place about spinal orthotics, and my guess would be that those presenters found the same thing, that when they went to the literature, they found that there were certainly limitations with the methodology. And what I mean by that is that the limitations are so great that many of these research projects are not reproducible. And so it's really hard to draw conclusions on what it is that we're doing. And so that really is, I think, the mandate, or I guess the request of the researcher, the physician, the orthotist, the entire medical team, is that we would be more careful in looking at the methodology. So John had mentioned the BRACE study. I think this really is a kind of a watershed moment, if you will. I think there's been a number of papers that have started to point the direction of there being this efficacy in that orthotic management would change natural history. And there are a couple things that obviously came out of this. One was the aspect related to dosage. And two things I think that were compelling with the dosage, and certainly this builds off of Rowe's meta-analysis and gives greater confirmation to the fact that dosage is the big part of the orthosis being effective, is that maybe we don't necessarily need to have the child in for 23 hours a day in the orthosis, because what the study implied was that a child who's in the orthosis 18 hours or 23 hours, that the results seem to be the same. Now, when you add in the social, psychological aspect, sometimes the physician needs to recommend the 23 hours, knowing that, in fact, the patient is not likely to wear it the 23 hours, but may, in fact, wear it less. What was also telling in this study was the fact that really if the person wore the orthosis for 6 hours or less, it was as if they never wore the orthosis, that essentially natural history was not affected in that case. John shared with you the other part of this in terms of the results, and that nearly 75% of the individuals that wore an orthosis did not have to have surgery. But the thing that sticks out to me as a person on the medical team is this piece right here. The initial hypothesis by the researchers was that only 15% of the subjects that wore the orthosis would require surgery, compared to, in fact, what they found, which was 25%. So as an orthotist, that troubles me that 25% of that population still needed to have surgery. Certainly the authors identifying, and I would concur, that there are a number of different factors that could influence that. Certainly the flexibility of the curve, I think we would agree, could have an impact there. But I can give you a bit of unique perspective. I was on the bracing committee for the brace study. So that was a compilation of orthopedic surgeons and orthotists. And what we would do is we would grade the in-orthosis films. I certainly don't want to say that I could tell you that there was something statistically significant, because that data still needs to be mined. And I probably wouldn't go as far to say that this is the trend I saw, but this is certainly the observation that me and the other orthotists saw. And that was that the designs frequently, there was suboptimal design features to the orthosis. And from what I saw, most of the time it was a result of the provider and not so much the design. So for example, some of the limitations that we saw, or some of the problems that we saw with the orthosis, inappropriate pad placement, not enough room for translation of the spine, essentially that there wasn't a window on the contralateral side or it was misplaced. Lumbar pads that were pushing on an apical vertebrae within the lumbar spine that extended down to and including the pelvis, so you're losing some of your translational force. Sometimes pads that were on the wrong side. So what does that tell us? When I've gone around and done accreditation with different programs around the world and have looked at the spinal curriculum, certainly a limitation has been the didactic piece, and we're hoping that this publication will influence or impact the didactic portion. But another major shortcoming, a challenge I think for many of the institutions, is the fact that it's very hard to bring in patient demonstration models. So to be able to take the didactic information and then actually to apply that is a big chasm. So I think there's a real opportunity from an educational standpoint to try to expand that. But again, acknowledging the fact that there are challenges to that and getting either real patients in or patient demonstrators. But clearly from the US, what we saw was that there was a shortcoming in terms of the way that the orthosis was designed. I want to switch gears and kind of land the plane with methodology, and that's kind of where I started out. A number of the other pathologies that we manage orthotically, when you look at the methodology, it's highly flawed. And let's start with low back pain. I think that's a good example. There really is no sound evidence when it comes to the efficacy of orthotic management for low back pain. Number of studies that are out there, I've seen some smaller studies where there have been some good results, but again, they're not long-term. The N was very small, so you can't really draw conclusions. And I've seen the results kind of on both sides of the aisle, if you will. So let me give you an example, because I think alignment is really the key feature here when you look at low back pain and the research that's done. And I don't feel that this is probably controlled the way it should be. So starting out with lumbar lordosis, if you take a look at normal lumbar lordosis, you'll see that really there's a wide range of what's accepted as normal lumbar lordosis. If you take that and then you apply it to put together a bit of a hypothetical, if you will, hypothetical chart, but maybe not so much. So you have a patient that comes in and they have low back pain. and you put them into an orthosis, and it's an off-the-shelf orthosis, let's say, that orthosis is going to essentially have a fixed alignment. So in this case, if we were to select an orthosis that had a fixed alignment of 30 degrees of lumbar lordosis, that's going to look different for each patient depending on where their normal lumbar lordosis starting point is. So if we go down to actually the bottom row, and we have a patient hypothetically that has a normal lumbar lordosis of 47 degrees. Well, that's consistent back with the previous slide where Lee et al. In 2015 showed that that was the average that they identified. So if we have a 47 degree normal alignment of lumbar lordosis and we put them into an orthosis that has 30 degrees, we may in fact think that we're putting the person into spinal extension when in reality we're actually flexing their spine. And depending on the diagnosis, we actually may make the diagnosis worse and the symptoms worse, or we may improve those. But this is something that I routinely, when I pick up these papers, it's one of the first things that I look for is, have they really controlled for what is the alignment that the patient's presenting with, and what is the alignment that is given within the orthosis? And I certainly, in this case, don't blame the manufacturer. I would put more on the orthotist that they need to make that determination of what is the appropriate alignment and to discuss that with the physician. So what do we need to do? I think we need to be more conscientious about how we are measuring, especially if we're talking about research. And there's a couple different ways that we can do that. We can certainly use a surface gauge, a goniometer. I recognize that there are limitations here. If you look at many of the studies, the intra-rater reliability tends to be pretty good. When you look at inter-rater reliability, one orthotist to another orthotist, or one provider to the next, measuring with a surface gauge that inter-rater reliability goes down, this at least is a step in the right direction versus the fact that in many cases, we're not even looking at this. So we at least need to get ourselves in the ballpark so we can get closer to drawing conclusions based on an informed decision. The other population where the literature tends to be limited and the methodology for sure is limited is with neuromuscular scoliosis. Most of what I see out there, the statement that's made is that orthotic management does not change the natural history of curve progression. And we really, when you talk about this neuromuscular scoliosis, it's really a large overarching umbrella. My experience is that I would really probably concur with that I think most of the time we're not able to change natural history. And yet, when you look at the methodology, there are a number of things that we still are making some assumptions on when I look to the literature. Some of the other benefits that have been described is that the orthosis is used to improve balance, certainly delay fusion, improve pulmonary function. I think one of the biggest problems that I see is that the statement that typically follows when you see that orthotic management does not change the natural history of curve progression, ergo, orthotic management doesn't work. And there are times where actually you put an orthosis on and there are other benefits. We may not change the natural history of curve progression, but there may be some functional benefits to the orthosis. What's unknown from most of the studies that I've looked at over the years is what are the specific design features of the orthosis. Force application. I have yet to find a paper where I could reproduce and see what force application they used that allowed them to have successes or why they had failures. And then certainly the alignment of the orthosis. But here's a good example right here. If you look at, this is a patient that was seen by a colleague of mine, had anoxia of the brain, was in a coma for 6 months, globally devastated. Spasticity was significant. And so, and it's hard for me to see here. I think the curve was 70 degrees, started out prior to orthotic management. The first orthosis was made, and the curve was brought from 70 degrees roughly down to 35 degrees. And then you'll see that a second orthosis was made. And in that case, the orthosis went from 35, or the curve went from 35 to 17 degrees. The only difference in this case is when the impression was taken, the force application was different. So if you look at the first orthosis, there was a constraint put on the superior end of the curve span and at the inferior aspect of the curve span. And then the big force application was at the apex, where really they were almost pushing into the inflexibility of the curve. What they did differently in the second was that they constrained at the inferior aspect and they held at the apex, and then they unbent at the upper portion, and that's where they actually got their greatest correction. So again, it's something that we probably need to look at more closely when we consider this population. So let me take us home with this case study and just kind of to underscore some of these points. This is a patient that I saw from Argentina. And one of the problems if you look at an x-ray first and you don't see the patient is you start to come up with these presuppositions, you draw your conclusions. And I certainly, when I saw this film for the first time, thought, well, there's no way. Why am I putting an orthosis on this patient? I'm not going to try to correct this. And when I talked to the orthopedic surgeons, they certainly didn't want us to try to correct it. They had no intention of doing surgery on this child whose diagnosis was spina bifida. But when you take a clinical look, there actually are some things that can be addressed here. And the things that stick out to me when I saw this boy was the fact that he really had sparing of his upper limbs. He had complete function of his upper limbs, and yet, as has been described in the literature, he essentially was a functional quad because he had to use his arms to balance himself. Not to mention the fact that because he didn't have trunk control, he had to flex so far forward at the hips that the only way to expand his visual field was to extend his neck back, where he's beginning to get discomfort as a result of that posture. So function's limited here. I can't really do anything in terms of changing the natural history, but we were actually able to do a number of things from a functional standpoint by putting this orthosis on. So we put this orthosis on. He actually had, the skin was very fragile posteriorly, so when we designed this orthosis, we actually had a posterior removable section just around where the gibbus was. So the medical team could, and the family could look at the skin to look at what the integrity was. But this is what the patient reported, certainly qualitative, but it was easier to sit. He was able to use his arms more freely, and you can appreciate that. Yes, he has his arms, he's sitting on an examination table, but his arms really aren't there to hold himself up. He's actually able to do that better because of the orthosis. He had reported decreased neck discomfort, decreased overall fatigue, wasn't as tired at the end of the day, and it was easier for him to see as well. And so the outcome here was not essentially based on correction of the deformity, but improvement on posture. And so the reason I give this final example is that, again, I think if we go back to what the methodology is, that methodology, if we were to do a case study on this or to write this up in a report, may look different than if we had just simply focused on trying to correct the deformity. So kind of final thoughts here in terms of future research and where I think we really need to go. And I think if we don't do some of these things, we'll be back here in 10 years and we won't be any better for it. So intentional about methodology, select the appropriate variables to address, and then I'll circle right back to what Dr. Fisk said at the very beginning. We talk about a team approach clinically. There has to be a team approach when it comes to the research as well. And if we have one or several players that are not part of that research, then that's where I think we run into problems in terms of not addressing appropriate variables. So thank you.